Much, and thank you everyone for staying here. It's a difficult thing to do, make cardiac rhythm disturbance easy at the end of the day when everyone is tired. So this would have been better first thing in the morning when everyone is fresh, but I'll do my best. So rhythm disturbances are either regular, irregular, fast, or slow. You can also have a combination. Irregular rhythms can be, as I said, can be fast, can be slow, and sometimes you can have a baby that is going slow and suddenly goes fast and it goes slow again. So you have to, if there is a persistent arrhythmia the whole time, it's easier. If it keeps changing the pattern, it may be more challenging. And then we have the normal rhythm, which is for most of the babies. And then just as a refresher, we don't normally look at the rhythm. If the heart looks like that, it's regular and is a subjective assessment. We can see the heart rate is within the normal and there is no irregularity, and it's not going fast and it's not going slow. Just to remind for those who are not cardiologists, which is the majority, and I think this is very basics, but I'm going to quickly go through a normal rhythm, which starts in the sinus node, which is located in the right atrium, very close to the SVC. That impulse goes into the atrioventricular node, and it goes through the Purkinje fibers through the myocardium. And the normal sinus rhythm has a rate of roughly 120 to 160. It is regular. There is a one-to-one atrioventricular relationship, and there is a constant time interval, or AV interval, between the atrio and ventricular contraction. So in order to assess the rhythm, we have to do simultaneous recording of some form of atrial and some form of ventricular activity. So how to assess the rhythm? The most conventional one, and probably the oldest technique, is through a Modo ecocardiography. This relies a lot on having a good image of the four-chamber view, because otherwise you don't get a good signal. And here I just put a line over the M-mode cursor line, so you simultaneously sample the ventricle and the atria, and here you see for each atrial contraction, you have a ventricular contraction on a one-to-one relationship. There are different methods, and some people prefer to use the mitral inflow and outflow tract. Apologies for this H here. So this is inflow, mitral valve, and aortic velocity. So you have atrial systole and ventricular systole, atrial systole and ventricular systole. So when the rhythm is normal, it's very easy to see there. Jean-Claude Fouhon many years ago described a technique using flow in the superior vena cava and the ascending aorta, again, simultaneous recording a retrograde wave of atrial systole and the ventricular systole on the aorta. And my preferred technique on a daily basis excuse me, is to use signal through the pulmonary artery and pulmonary veins, because you have lots of places where you can sample. You can see here that you see a vein coming together with the artery going to the lungs. And the typical signal is kind of resembles an electrocardiogram with your atrial systole and your ventricular systole. And then you can very quickly sample that and you can hear the sound at the same time. So whatever method you use, be familiar with that, and it's always nice to use two different methods, because sometimes one is more difficult than the other. Then we have the atrioventricular time interval, which you can measure in all of these techniques. As I said, this is my preferred one. You measure between the beginning of atrial systole and the beginning of the ventricular systole, and that's your AV interval, which is useful when you're looking at AV block and also when monitoring pregnancies with anterior. But what is the normal AV interval in the fetus? And there's a very nice paper that you can use as a reference. This was published a few years ago. You should look at the different AV interval and 3 different methods using Doppler. And I'm just going to simplify to you a little bit here, but you can go to the original paper. These are mean values for the left ventricular inflow and outflow in the pulmonary artery and pulmonary venous Doppler signal. You see the pulmonary veins is slightly prolonged compared to the left ventricular inflow, so going from 110 to 120, or in the pulmonary vessels from 120 to 140 as a mean value. But what we're really interested are the standard deviations, the 2 and 3 standard deviations, if we're looking for prolonged AV interval. And again here, just as a rule of thumb, in the left ventricular inflow, outflow tract, 3 standard deviations go, depending on the gestational age, from 130 to about 150, and it's slightly more prolonged in the pulmonary vessels. So let's look at irregular rhythms, because they're quite common. And I think although many of the talks on arrhythmias, we concentrate on tachycardia and bradycardia, this can be a pain because the midwives hear ectopic, they panic. We don't want to receive the referrals for all the irregular rhythms. So I don't know if you can hear that, but it's very common. They don't see the heart. They send for a scan, either for a cardiologist, and that's what you see on an irregular rhythm. Most of the time, these are atriectopics. They are the most common form of irregularity of the rhythm, and they're benign in the vast majority of cases. So if you ignore them most of the time, you'll be okay. But however, in a small proportion of cases, this can be a problem. So there's a small risk of tachycardia. It's a small risk, but it's an important risk, and can also lead to bradycardia, and it can more infrequently be second-degree AV blocks. So it's important to differentiate them. So in about a small proportion of babies, the irregular rhythm can be important. So what we don't want to see is all of these babies being referred for a detailed fetal echo, because we'll be inundated with referrals. So just a quick recap here, how we look at the atrial ectopic if you're using the pulmonary artery and pulmonary vein. So atrial systole, ventricular systole, and in the image below we have an atrial ectopic, not conducted. You see an A wave conducted, an A wave conducted, another A wave. Why do we know it's an ectopic? Because it's early compared to the normal regularity, and this one is conducted to the ventricle. If you're using the inflow and outflow, you hear a normal rhythm, E and A wave followed by a ventricular systole. Here we have a normal one, a ventricular systole. We have an ectopic, just an A wave followed by a ventricular systole. So this is conducted atriectopic, and this is on the traditional M mode. Again, we see regular A waves, and suddenly we have an early signal, which is an ectopic. So the rhythm irregularity can less often be due to ventricular ectopics. And here's a comparison on the M mode of A wave, and an early one, an atriectopic. When you have a ventricular ectopic, the atrium goes in its normal pace. So there is a regular atrial rhythm, and then if the ventricle comes, and suddenly we have an early one, so it's a ventricular ectopic. Not the most common reason. Sometimes it can come very frequently, like in this case, the atrium is going regularly, the ventricle is going in a bigeminy, so a normal one, which is following an atrial contraction, an early one. So this is bigeminy, ventricular bigeminy. In this baby, there was some repercussion, there was some mitral and tricuspid regurgitation, but it resolved spontaneously. We just followed this in case there were ventricular tachycardia. Another fetus, you should always think, if it's very frequent, to look for, like in this case, a left ventricular aneurysm, which was the focus of the ectopic. And this baby had 2 normal signals in the ventricle, 1 ectopic, whilst the atrium was going at a normal pace. So these are probably the case that we need to pick up. And if you had a look at the white journal, I tried to put here, it looks very complicated, but I'm going to take you through this because it's relatively simple. So if you look at an irregular rhythm, which is very common, and you are scanning and the baby's unwell, where you see high drops or whatever, that baby may be having tachycardia. So that's not what I'm going to talk about. I'm talking about an incidental finding. When the woman goes for the antenatal department, the midwife listens to the baby's heart, here's an ectopic, or you're doing a scan, the sonographer is doing a scan, and there are irregular rhythms. So the first thing to see is what's the fetal heart rate, which quite often people don't say, it's just irregular rhythm. And that helps us to stratify how to follow these babies. So if we look at the normal rate, so it's irregular, but it's going between 120 and 160. This is the vast majority of babies. The next question is, how frequent are the ectopics? And most of the time, they are isolated, one here, one there. They are most likely to resolve. So I don't want these babies referred. What anyone can do in this audience is what I call a local scan. it's no need to refer unless there is concern on that local scan, which is really like a growth scan. You look for fetal movements, you look for the amniotic fluid, there's no evidence of heart drops, effusions. You do look at the heart to make sure that there is no cardiac abnormality, and if you're using column, there is no AV valve regurgitation, because if that baby is having intermittent tachycardia, it may just be AV valve regurgitation, a sign that that baby at other times has an important abnormality. So most of the time, as I said, these are the common ones. They resolve, and then they can be discharged without a referral for a specialist scan. This is an example, an isolated atriectopic. You should do a scan, but it doesn't have to be a very specialist scan. Normal movements, normal cardiac views, normal amniotic fluid, no effusions, likely to resolve, and it did resolve spontaneously. So if they are frequent, and by frequent I mean they occur every 3 to 5 weeks, sometimes every other one, this is a group that we want to clarify and want to monitor them, because there is about a 5% risk. It's not a very high risk, but it's an important risk of the baby developing tachycardia. So these babies do require more specialists, be an obstetrician that's familiar with arrhythmias or a cardiologist. You can do a local scan if you are happy to assess that, but if you're not, that baby does require monitoring because they could develop an SVT and prolong and go into hemodynamic compromise. So this is the lady that was referred. You see the pulmonary artery, pulmonary venous signal. The signal is not the same. We have an atrial systole from a ventricular systole, a normal by a ventricular systole, a normal. Here's an ectopic. It's ectopic because it's coming early. This one is not conducted, so we're having a normal, 2 normal for 1 ectopic. There's a trigeminy giving you an irregular rhythm. There is a risk of tachycardia. You don't know if they're going to develop. The scan showed no sign of compromise, and in this case, it resolved spontaneously. But you don't know which ones are going to resolve. This one, again, refers for very frequent ectopics, 29 weeks. You can see a similar pattern here, but if you look here, there is already a sign there that this baby may be in trouble. At other times, a little bit of a pleural effusion, the amniotic fluid was a little bit on the high side. 2 days later, that baby is in SVT. You see a bit more of a pleural effusion. There was a rim of ascites, and that's the baby in tachycardia. So we do want to pick up these babies, and the frequent ectopics is the one that need monitoring. So that's the most common, and most of them are going to resolve spontaneous. And if the heart rate is a little bit slow, 110 to 120, or very slow for bradycardia, very fast, this can be persistent or intermittently. And this requires further assessment because just occasionally this might be a sign of something that's important, either genetic or heart block. So I'm now going to merge the irregular rhythm with fast and slow because the fast rhythms can be, sorry, go back again. The fast and the slow rhythm, they can be regular or irregular. So we start with the fast rhythm, regular or irregular, and you can see here baby in tachycardia, a bit of a pleural effusion. We need to try and identify the mechanism if the rhythm is going fast, because the mechanism will tell us about treatment and the best treatment to offer the babies, at least as a first line, which I'm not going to talk about the treatment because there is no time for that at the moment, maybe on the discussion. So the main mechanism will be an SVT, supraventricular tachycardia, with a 1-to-1 atrioventricular conduction, atrial flutter, or ventricular tachycardia and junctional ectopic tachycardia. These are the 2 most common ones, and I'm going to concentrate on them again for the interest of time. So within this SVT, with 1-to-1 conduction, we can have what's called a short ventricular atrial interval or a long ventricular atrial interval, and these are the types, and I'm going to show you some examples of these. For an SVT, which is 1-to-1 conduction on the M mode, this is the normal one, so it looks very similar, except it's faster, and you can see here it's intermittent, it's going fast, 1-to-1 conduction, and suddenly goes into a normal rhythm, slower, and then it goes back again. Again, on the M mode, it's very easy if you're familiar with that, to stick to that, but try and learn a second technique. I find it quite difficult here to measure the AV interval because you can't quite show where the atrial and the ventricular systole start. This is on the pulmonary artery and pulmonary veins, and if you capture this on a tachycardia, this is a typical, what you call a reentrant mechanism, and this is the typical SVT, when the signal, which starts somewhere in the atria, if followed down the atrioventricular node, which is relatively slow in that AV interval, and these babies have what's called an accessory pathway, which conducts backwards, retrograde, and that pathway is the fast conduction. So it comes down slow and goes up very fast, and that's how the signal looks completely different from the normal pulmonary venous Doppler signal. And if you look here, this is going towards the lungs, and this is going away from the lungs towards the left atrium. So what you see in this case is the rate is usually quite fast, 220 to 240, sometimes 260, 280. You see that there is a summation of the S and D wave and a reverse of the A wave. So within the vessels going to the lung, you see a ventricle from the artery, and you see a reverse A wave. This gives a short VA interval, which is reflecting that this baby has an accessory pathway. This can lead to high drops in many cases. After birth, babies can still have that, but they tend to resolve with time. Very few babies long-term will need treatment for this. Then we have a different type, which is a long VA tachycardia. For the cardiologist, a long RP tachycardia on the ECG. The heart rate is usually a little bit slower, but not necessarily. You can see here around 200. It resembles more the pulmonary artery and pulmonary venous Doppler signal. And if you measure the VA and the AV interval, the VA interval is slightly longer. So this is a different mechanism. This is an ectopic tachycardia. The sinus rhythm in sinus tachycardia will have a similar waveforms, and there is something that's less frequent, which is a permanent reciprocating tachycardia, junctional reciprocating tachycardia. So this is an example of atrioectopic tachycardia. So this is very briefly talking about SVT with one-to-one conduction. Another type is atrial flutter, and is most commonly on a 2-to-1 atrioventricular conduction, giving a regular tachycardia. But it can be variable conduction, so it can be irregular as well, sometimes blocking 3-to-1 or variable. So the heart rate sometimes can be around 180 and 190 in the ventricles, and the atria can be going at 400 plus. So this is a typical M mode of 2-to-1 atrial flutter, and you can see that there is one wave that is less clearly seen and another one is more pronounced, because one of them is going to be conducted. And sometimes it's quite difficult to see the two of them, so sometimes you may just see the most pronounced one, which can sometimes lead to a false diagnosis of a one-to-one conduction. In the pulmonary artery, pulmonary venous signal, this is the typical sign of atrial flutter. You don't have time for having that reverse A wave as you have on the reentrant mechanism. These are just atrial flutter, so you can see you have two of them at different amplitude because one is conducting and one is not, 2-to-1, and there's a very typical signal. If you see this, you know it's atrial flutter. Now I'm going to move from slow rhythms, regular or irregular. Again, is important, perhaps even more important, the slow rhythm to differentiate between the mechanisms, because the treatment can be quite different, and or reassurance. So we have sinus bradycardia, which is a one-to-one AV relationship. So it's a normal rhythm, just slower and is regular. We have an ectopic related bradycardia, and we have heart block. And both of these can be regular or irregular. So let's start with the sinus bradycardia. The rate, you might say, is below 110 beats per minute, but that's because the American College of Cardiology definition of bradycardia is a fetal heart rate below 110, and this was established based on CTG and is applied for intrapartum or peripartum, antepartum observations. So that's a kind of a general definition of bradycardia. However, more than 10 years ago now, a paper by Mitchell has shown that the heart rate is, that flat value of 110 is different from what you can get on a gestational age. And this paper has nicely shown centile charts. You can see most of them are obviously within the normal. A few babies are below the 3rd centile. This is important because for fetuses who are referred with a history of long QT syndrome, a large number of them will have a heart rate below the 3rd centile, but is still above the cutoff of 110. Lots of them will have a normal heart rate because they may not have inherited the gene for long QT. And other fetuses that are referred because of rhythm assessment, again, a lot of them below the 3rd centile, but a more significant number even below 110 beats per minute. So people can be quite worried about the bradycardia, and it's important because the management, the main reasons you can have a low atrial rhythm if you have isomerism, so sometimes babies just have a heart rate of about 110, 120 in the setting of left isomerism, which is usually due to a low atrial rhythm. But important here is the inherited cardiac conditions, of which long QT syndrome is one of them. There are other types of more complicated inherited conditions. And just occasionally a woman has anti-row, anti-lab presenting with sinus bradycardia rather than AV block. So in case of sinus bradycardia, it's important to do a detailed echo, a detailed history in the family. Is there any history of sudden death, history of people having syncopes? It's important to do parental ECGs, mother and father, and also to check maternal autoantibodies. And it's very uncommon, but it may not be benign. Coming up in a forthcoming issue of the ESWOG, of the UOG paper, one of my colleagues has put together, so it's uncommon, but it's not always benign. So watch out for that one. So this is the lady that was referred at about 27 weeks, and you can see that the heart rate is slow. It was one-to-one relationship, heart rate of 109, so this is clearly bradycardia by all definition. There were 2 generations of women in the family with bradycardia, and they were all perfectly well, no other history. The QT interval on both the mother and the other relatives were normal. Unfortunately, she was lost to follow-up, but we suspect that was a genetic cause, but it was relatively benign because they were 3rd generations of babies with a slower heart rate. Another example referred at 30 weeks, again, looks very similar, sinus bradycardia, 30 weeks. If we do the signal, we can see there's a one-to-one conduction, heart rate about 108, the AV interval was normal, so by definition, sinus bradycardia. The neonate had a prolonged QT interval, and there was a genetic here on the KCNK1 for long QT syndrome. So we've gone briefly through sinus bradycardia, and these 2 here are related, and they can be sometimes quite difficult to differentiate with completely different management. They can have similar heart rates, different mechanisms, and most importantly, different management. So let's look first at regular bradycardia due to ectopics or AV block. So here are 2 examples. One case is heart block. One case is blocked by Gemini. And it will be impossible to tell you which one is which, and of course the implications are completely different. So if we look at these 2 babies on the Doppler signal on the umbilical artery, there is no way of differentiating that. One heart rate around 86, 76, you can't distinguish which one is pathological, which one may be benign. So that one was blocked by Gemini, and the second one, it was a 2-to-1 AV block. If we look at the simultaneous atrial ventricle, we can see that on by Gemini, we have 2 signals together. One normal conducted to the ventricle, one ectopic. This is a very early ectopic, so it was blocked. And therefore, for 2 atrial contractions, but they are close together, we have only one ventricular contraction. Whilst in the AV block, we have an atrial contractility which is regular, and the ventricle, only one response. So one is conducted, one is blocked. One is conducted, one is blocked. So they both have a form of block, except that the first one is physiological and the second one is pathological. So if we look at the pulmonary venous signal, we have an atrial systole, conducted, and another one, very early, blocked. A normal systole, conducted, and a normal one blocked. So this is a very same baby, showing two different methods of distinguishing between blocked by Gemini with a heart rate of around 80, an AV block with a similar heart rate, a normal one, a little bit more difficult to see the other one, but that interval here would be twice as long as the interval here. So this is physiological AV block, and this is pathological AV block because it's blocking a signal that should have been conducted, whilst this is blocking a signal that shouldn't have been there. Implications completely different. So this one was blocked by Gemini. You can reassure the family that it's going to resolve most likely, but it still has a 5% risk of the baby suddenly flipping into supraventricular tachycardia. And this baby was a second-degree AV block. It was maternal anti-Rho positive. The implications are completely different. They look pretty similar, and it's impossible to distinguish on an arterial signal alone. Another type of regular bradycardia is complete AV block. This was a second pregnancy affected with AV block. You can see the function is good, but the heart rate is slow and it's regular. And again, you can see complete AV block using two methods. I'm concentrating on those two, atrial signal, regular, and ventricular systole. Regular, but there is no relationship. We have here, if we synchronize that atrial here with the ventricle, they're very close together. If we look at this one, they are different. If we look at another one, they are different. So there's no synchrony between atrial and ventricular contraction. So this is complete AV block, which is also seen on the pulmonary venous signal. We see an A wave here. We see one here which is reversed because it's very close to the contraction. We see another one here. So there is no relationship between the atrial contraction and the ventricular contraction. Coming out towards the end, irregular bradycardia. These are all combined ectopics and heart blocks. So if you see this, there's no way of distinguishing between ectopics or heart block, although the ectopics are by far the most common reason. So you can't just assume these are ectopics. And you need to do the same exercise. This one is irregular, so we come in two together. This is blocked trigemini, and this is 3-2 AV block. So no way to distinguish them on the arterial signal. If you look at the M mode, for the ectopics, we don't have regularity. We have two signals separate, one together. So one normal conducted, one normal conducted, one ectopic because it's early blocked. So this is blocked trigemini. We have two normal and one ectopic. Whilst on the case of AV block, in this particular one, we have two conducted, one blocked. Two conducted, one blocked. So this is 3 atrial systoles to 2 ventricular systoles, 3-2 AV block. Again, we can see them on the pulmonary artery, pulmonary venous signal. Again, AA, similar to that, blocked ectopic, and a gap. So two signals on the artery. And in this case, which was a 3-2 block, is a second-degree block. If you actually look, the interval between the A wave and the ventricle is relatively short. Between this and the second ventricle is long, and between these and there is a blockage. So this is a prolongation of the AV interval, and one is blocked. This is what's called a Wenckebach, second-degree AV block. Completely different implication, very similar arterial signal. This is a physiological block because it's blocking an ectopic, and this is a pathological block because it's blocking a sinus conduction, a sinus beat. So this case of irregular bradycardia, it was the case that I showed with second-degree block with the 3-to-2 conduction. So this is not meant to be about management, but I think the ectopic-related bradycardia and the heart block, most of them are ectopics, and the management is completely different. So for the ectopic-related is conservative. There is a minor, but it's a significant risk of tachycardia, so we need monitoring. And the main message is do not deliver the baby. So if the baby is bradycardic, you're not concerned about fetal well-being, the baby is moving, there is nothing else, there is no fluid accumulation, you're happy about everything else, just get a detailed assessment of the rhythm. Most of the time, this will be ectopics, and most of the time with the regular bradycardia, it's going to be a blocked HO ectopic. And the outcome is good, yeah? A percentage of them will develop a tachycardia, which we can treat and we can slow down the heart rate. While for the heart block-related bradycardia, it's completely different, and here are different types that I've shown you some examples. The management is different. You need to check anti-Rho, anti-Lie status. Most of them are due to autoimmune disease. There's lots of questions about the use of steroids. We do use steroids now. We follow more or less the Toronto protocol. We give steroids from the moment of diagnosis of heart block. Salbutamol can be used in a very small number of cases. Some of my colleagues have a couple of cases using immunoglobulin in cases where you have a lot of associated myocardial problems, and this was some research many years ago, but it hasn't really taken off. But it does require specialist follow-up, and these babies, one way or another, will end up having a pacemaker. I think most of you know that there's hydroxychloroquine. There's a very elegant study that's been conducted a few years ago that showed that the use of hydroxychloroquine for mothers who have had a previous baby with heart block, 400 milligrams daily, starting from less than 10 weeks of gestation till the end of pregnancy, reduced the risk of heart block from 18%. The recurrence risk for anti-Rho, anti-La is quite high to about 7%. So it doesn't eliminate the risk, but it actually reduces the risk. The baby I showed you, complete heart block, was actually a recurrence. She was on hydroxychloroquine, and unfortunately, it did not prevent it. So there's a second baby with heart block. So in summary, we have irregular rhythms, fast and slow. The irregular are mostly benign, with a 5% risk of tachycardia. Those can be dealt with by the obstetricians, the fellows, without a need for referral, but you need to know which ones to refer. They're small proportion. And fast and slow rhythms, they can have, the mechanisms will inform the treatment. For tachycardia, mainly SVT and atrial flutter is slightly different medication, and accurate differential diagnosis is very important, and that requires a specialist assessment. Thank you very much. I hope that hasn't been too difficult.